Dr. April Pettit walked down the hushed, fluorescent-lit hallway in Vanderbilt's critical care unit, the beeping of machines and the murmur of nurses greeting her as she started her shift. Just a year earlier, she had finished her fellowship and been hired by Vanderbilt as an attending physician. The 34-year-old Pettit had a degree in public health and expertise in infectious disease, but she had little experience with cases of meningitis like the one in the patient she'd just inherited. She scanned his paperwork. Thomas Rybinski was a man in his 50s who had been healthy except for the back pain he felt when he rode his motorcycle. He was deteriorating quickly from meningitis of an unknown origin. To complicate matters, he could speak but was not making sense, so she had to rely on his medical records and his previous interviews with her colleagues for clues. Pettit studied Rybinski's medical history and charts. Her first task was to build a differential diagnosis, a list of possible causes of his meningitis and stroke, ranked from the most likely to the least. From there, she would move from the top of the list to the bottom, methodically ruling out potential causes one at a time. Bacterial meningitis was still the odds-on favorite, but he had not responded to antibiotics, and they had started him on an antifungal too, just in case. There were other meningitis-causing microbes she needed to cross off the list, like viruses. So far, all the labs were coming back negative, including a battery of tests of Rybinski's spinal fluid. She was still waiting for the results of a fungal culture, even though fungal meningitis had almost never been diagnosed in previously healthy people like Rybinski. Fungi usually have no clear pathway to a human spinal column. In fact, the lab at Vanderbilt had not grown a fungus in a spinal fluid sample for nearly 30 years. But Rybinski was short on time. At the very least, a negative culture would allow Pettit to cross fungus off her differential diagnosis. Across the street, inside a sterile room the size of a walk-in refrigerator, the lab tech had put 3 samples of Rybinski's spinal fluid into separate vials. One held a sugary solution called sabarod agar, another used a form of mucus, and another was a crimson concoction of blood and brain matter. The tech had performed these cultures for decades, but that last one still grossed her out. Typically, if the fluid stays clear after a week or two, it's considered free of microbes. But some fungi could take weeks to show up, and hospital officials decided to monitor the culture until the process had run its course. While this was sound medical practice, it was also a problem. Rybinski's condition continued to worsen. 6 days after Rybinski was readmitted, his face was drooping on the right side, a sign of an intensifying stroke. A CT scan of his head revealed excess fluid around the brain. The doctors also found blocked oxygen-providing arteries in the back of his head. In Rybinski's scans, reproduced later in the New England Journal of Medicine, the ghostly image of his brain is clearly wrong. Tidy folds of tissue are interrupted by what looks like an off-white cluster in the center. Even to a layperson, it is obvious that this mass should not be there. Notes attached to the scan identified the anomaly as a pool of blood that collected near where the brain and spine meet. Similarly, the arteries that fed his brain were weakened by aneurysms, which had burst and bled into surrounding areas. These were the obvious ravages of an invasive species adapting to an unfamiliar ecosystem, Rybinski's central nervous system. There it had grown and multiplied, interrupting the flow of blood to his brain. This caused a stroke. What the images did not explain was exactly what was causing this, or why. The next day, in a refrigerator behind a door marked biohazard, one of Rybinski's cultures started changing. Where there had been clear spinal fluid, there was now a fuzzy mound of blue-green, the microbe up close. The technician was shocked. She needed to report the results immediately. Pettit stood with her medical fellow in Rybinski's cramped room in the intensive care unit, the only sounds coming from his softly beeping monitor. Colette was sitting in a chair near her husband's bed when the fellow's pager lit up. It was the lab. The medical fellow left the room to check in and returned with Rybinski's results promptly. Pettit asked that the results be shared with Colette. This was an excruciating part of the job. The fellow said that Rybinski's culture had grown a fungus. Pettit felt relieved at a diagnosis, but also confused by it. She had heard of mold meningitis in organ transplant and HIV patients, whose immune systems were compromised by their conditions. She knew that mold could also cause infections in people with open wounds or cuts, but rarely meningitis. Rybinski simply did not fit any profile she had seen or read.